시청자 여러분 안녕하세요.
Hello, ladies and gentlemen. Another Prosthodontics on Friday session to go over prosthodontic treatment steps easily and with fun. Side effect problems will be clearly addressed. Back to the basic, complete dentures. Professor Soo-hyun Lee will talk about selection and arrangement of artificial teeth. Is it important for aesthetics and function? Hello, Professor Lee. Thank you for visiting us from all the way from Busan. I believe you have appeared in denall programs a couple of times. However, this is your first time to appear on this program of Prosthodontics on Friday. Would you briefly introduce what you're going to talk about today? I believe the audience has learned the basic things in this Prosthodontics on Friday seminars. On the basis of that, I'm going to talk about selection and arrangement of artificial teeth to successfully fabricate complete dentures. Listening to your comment, I really look forward to your lecture today. Those who are watching the denall broadcasting site, you can communicate with us real time through the chat. Leave your questions in the chat and get the answers real time. Starbucks coffee coupons will be sent to you. We will choose the most impressive questions, so the best questioner will receive a Vusen Music Tiger dental set. You can study complete dentures and be lucky to receive some gifts. Your active participation is called for. Let's get started with the Prosthodontics on Friday. Greetings. I am Professor Soo-hyun Lee. I'm with the Busan National University School of Dentistry Prosthodontics Department. It is my honor to be invited to this OSSTEM Prosthodontics on Friday. Today, I'm going to talk about the selection and arrangement of artificial teeth for complete denture treatment. In fabricating complete dentures, is it important for aesthetics and function? That is the topic of today. Let's have a more in-depth discussion on that. In this hour today, we are going to talk about selection and arrangement of artificial teeth, and this is not a very easy topic to deal with. I don't know how much I can cover in this hour, but I will talk about theories and the clinical experiences. Let's have a discussion on that topic. As you can see, these are the patients with difficult conditions. As complete dentures are covered by the National Health Insurance now, many patients come to us who have not received the proper denture treatment. You can find various problems with these conditions if you listen to Prosthodontics on Friday seminars. In addition to the incorrect interjaw relationship setting, occlusal or plane setting, there's a big problem with the selection and arrangement of artificial teeth, which is the topic of this seminar. You need to find the problems with the patient wearing the existing denture in order to fabricate proper complete denture. If you look at this patient, if you look at him aesthetically, it is quite improved and the patient is chewing very well, and that led to improve the quality of life for the patient. Can you find any problems with this patient? There can be a variety of problems, but there's clearly poor interjaw relation and lack of maintenance. A new denture was provided, resolving the discomfort issue with the existing denture. This was a rather old case, and the denture was completed. If you compare the before and after photos of denture delivery, there's a lot of changes, more aesthetic, and the chewing function has improved, and the patient gained more confidence in life. As you can see, a variety of problems when patients visit. Complete denture treatment is not easy. When we make efforts, the surgeon and patients can make efforts to make improvement, and then it is rewarding to see the result of the treatment. So we need to make efforts to improve aesthetics and function, which is the topic of today, especially selection and arrangement of artificial teeth. Let me talk about some theories. For complete denture treatment for edentulous patients, we need to study artificial teeth, which are replacing natural teeth. The structures are divided into anterior and posterior regions, maxilla and mandible. You can choose from the various shapes and sizes and colors provided by manufacturers. As indicated in the right bottom, manufacturers have the markings regarding shapes, sizes, and shades. You need to have them in your office and choose appropriately according to the brochure. Usually, teeth arrangement is done by lab technicians based on the information that we provide. However, we can do it ourselves when we repair them. You may choose them yourselves, or you can check the arrangement done by others, and you need to have some knowledge about this. In the middle, you can see teeth with retention hole or pin that you can choose. Acrylic resin teeth used to be used with a low resistance to wear. So it is for temporary teeth, and for final teeth, hard resin is used. Let me introduce IPN artificial teeth from dense ply with higher resistance to wear using high cross-linked polymer. If you look at the guideline, so they send you the guideline like this, and you can choose from anterior, posterior regions, Evoclar Vivadent, and it looks like a book, easy to use, and the shade guide in the middle is included. And there was something like a video book. Teeth rotation can provide more natural look, so the samples are provided to show them to patients. GC had a Duradent, and recently they introduced a Surpass G and gave me the samples. At the bottom, you can see the gauge provided by the company so that we can choose the length of teeth depending on the alar width. Busan University uses Endura from Shofu quite a lot. The Endura is using complex resin containing fillers like the ones you saw before. Caution: these are hard resin teeth that need to be attached to the denture base to increase the bonding strength to the denture base. There is acrylic resin layer at the bottom of the teeth. Therefore, for teeth arrangement or to adjust the cusp angles, sometimes we need to cut the bottom part of the teeth. Then denture base bonding strength can be decreased. When you need to adjust the base, you need to be careful about this. Keep that in mind. Functions of anterior teeth: aesthetics, phonetics, and incision. They play very important roles for these. You may already know. Let's remind ourselves of these. When choosing anterior artificial teeth, the sizes, we need to consider the following. As you can see on the right, occlusal rim is formed and they are delivered into the mouth, and we need to check these markings to ensure proper arrangement of teeth. For the anterior teeth, we need to look at or check the length of incisal edge, mesiodistal thickness, and left to right width to determine the anterior teeth positions in 3 dimensions. These are the photos of many patients. I regard smart line very important, so I take many pictures. Among others, I try to match the interalar width with the canine tip to tip. There can be some deviations though. If those two are not matching very well, and if there's a lot of discrepancies, you need to clinically check the situation again. So the distance to the corner of mouth is to the distal surface of the upper canines, and the interalar width is canine tip to tip. But If a patient has a big smile and has a big open mouth, even premolars can be visible. As I said before, a gauge is available to determine the length of anterior teeth depending on the interalar width. Incisal papilla serves as an important landmark for positioning of the upper teeth. You need to be careful in dealing with edentulous patients. Incisal papilla can be changed depending on the bone resorption in the anterior region. Incisal papilla does not change drastically, but it can be rotated counterclockwise. Therefore, existing tip cannot serve as an important guideline for positioning. Usually, 8 to 10 millimeters anterior from the center of the incisal papilla, central incisor should be positioned. As we know, but if there is severe bone resorption, the papilla would be rotated counterclockwise. So we usually use the posterior border of the incisal papilla, which is relatively well maintained. So the landmark would be 10 to 12 millimeters from the posterior border of the papilla. On line connecting the incisal papillas would pass the tips of canines. But if bone resorption is progressing, the position can be changed. Therefore, it would be better to use the posterior border of the papilla to determine the canine tips. Another tip, canines are positioned 2 millimeters outside from the prominent rugae. So this is another checking point when you check the teeth arrangement performed by yourself or by someone else. There are slight variations among patients, but these can be checked as landmarks when you check the arrangement. Another checking point, the posterior teeth palatal surface should be positioned on the line connecting the canine mesial contact point and hemulot notch. When you check the teeth arrangement, so I have introduced the various points to check teeth arrangement, and as you can see here, not only in the mouth but on the face, there are landmarks that we can use. I don't really memorize all of them, I just refer to this. Facial color is very important, so matching the facial color using the shade guide, we can select the color for the teeth. As you can see here, as you saw before, teeth can be selected using a guide. You can also use a tooth selector to compare with wax denture or occluso rim. We used to use them, but these days not easy to get them, so I make something like that by attaching teeth. So if you have teeth frequently used, you can use the technique. In selecting anterior artificial teeth, we need to consider facial muscle movements and tension. Muscle tensions would be different between senior patients and young patients, and we need to check the facial muscle tension level of a patient, as the incisal edge position would be determined by the position of lips. Necessary, as you can see here, there are many muscles indicated for your reference. Among them, the mechanism of articularis modulus and buccinator muscles would be very important. The modulus muscle is very important in determining the position of posterior teeth. After studying three-dimensional positions of anterior artificial teeth, mesiodistal labiolingual inclinations will be determined. If necessary, aesthetically, rotation should be considered. We set the positions of anterior teeth and arrange artificial teeth, and if we think about the sequence, first we need to consider midline and harmonious anterior teeth, but the midline is not an easy subject because the patient's faces are not always symmetrical. So dentists should have an eye for aesthetics to catch whether something is symmetrical. Usually for the midline, we look at the glabella, the space between the eyebrows, nose tip, and chin tip. Many people do not have nose and chin tips in straight line, including me, so I try not to look at the nose tip. Because when we look at a nose, they're usually off. It is seen from behind the patient and it will not work if you focus on the nose tip. You need to look at the patient from the front side, and I look at the glabella and I focus on the philtrum line, which is a very important position in determining patient's aesthetics. If the landmarks for the midline are all off, you need to focus on the philtrum for harmonious positioning. You need to discuss the matter with the patient and you need to practice to look at a patient from afar and from the front side. Bone resorption should be compensated by a denture base to support lips. When we make an occlusive rim and insert it in the mouth, we need to check the midline first, followed by the mesiodistal lip support. More denture base is necessary for more bone resorption. We cannot just focus on aesthetic lip support because if there's a cantilever in the anterior denture base, bone resorption will get more severe. As shown in the photos, the lip support will determine how long the upper lip would look. We look at the upper lip position in determining the length of incisal edge. Therefore, determining the position appropriately at the beginning is important in determining the teeth length. We easily make mistakes here. After extraction, alveolar ridge would be resorbed, which leads to gingival recession. If we mount the teeth on the ridge, patients would not have proper lip support. So artificial teeth are labially positioned compared to natural teeth. Today, from time to time, I notice dentures like in the upper photo where they are just mounted on the ridge without proper maintenance and they look protruded. In that case, there's a problem aesthetically in speech and function, so we need to check the level of bone resorption before using the denture base for lip support. In selecting artificial teeth, we need to look at the arch form of a patient, whether the teeth are square, ovoid, or triangular. After considering all of these, after selecting the teeth, as we did a lot in hands-on classes, we need to look at the inclinations. Like here, we cannot go over all of these due to constraint of time. However, we need to remember one thing. We need to check canine inclinations when wax denture arrives. As you can see, the canine is inclined and it is not possible to see part of the canine. So you need to check the canine position. We know a complete denture requires balanced occlusion, and I'm going to go over this when I talk about occlusion in the posterior region. Here, the incisal guidance plays a very important role. We will look at the incisal guidance when we arrange anterior teeth. Incisal guidance is very important for aesthetics, speech, and the stability of dentures. I have prepared this slide for you to study. For a complete denture, it is very important. The vertical overbite between the upper and lower anterior teeth should be 0.5 millimeters, horizontal overjet of 1 to 2 millimeters. This is important. It is different from natural teeth. In an edentulous case, a denture base is moving as one unit depending on the condition of tissues. The teeth do not stay still as we established. They are always moving, and we need to consider the range of their movement so that upper and lower anterior teeth do not come in touch with each other. They have to keep some distance. An incisal guidance angle is formed between the line connecting the vertical and horizontal overlap and the horizontal plane. For the denture stability, the incisal guidance angle should be formed low if possible. As you can see here, there is the sagittal condylar guidance angle, which is unique to each person, which we cannot change. We will go over this later. So the angle of the posterior artificial teeth should be set about half of the IGA and SCGA combined. This is not easy to follow, but we learned Hanau quint, which is used by us and lab technicians to arrange teeth. We also need to understand this equation. As for the condylar and incisal guidance, at both ends, there are ending controlling factors. The two, condylar guidance is unique to a patient which cannot be controlled by a surgeon, so that's orthodontic factor. A surgeon should set the incisal guidance angle as low as possible to stabilize dentures. However, we cannot afford to keep it low always for aesthetics, speech, and mechanical stability of dentures, so there should be compromise. For that, we refer to the occlusal plane height, artificial teeth inclinations, and anatomical structures. For occlusal plane, we look at Camper's plane and interpupillary line and the like. As anatomical indicators are used, they are not completely fixed factors but semi-fixed factors. You need to be able to look at anatomical indicators. So you need to understand that according to the determined incisal guidance angle, balanced occlusion can be formed based on the artificial teeth inclination of condylar guidance, cusps, and the prominence of compensating curve. You need to separate the tasks done by us and done by a lab technician, and you need to check them when patients visit. Considering the posterior region, when IGA is very big and you choose very low cusp inclination, for the balanced occlusion, very big compensating curve would be necessary. That will lead to non-functional, non-aesthetic occlusal form. On the contrary, when IGA is low, artificial teeth with a big inclination of cusp would be selected, requiring aggressive cusp reduction. So together with IGA, artificial teeth in the posterior should be considered. Here it shows a complete denture patient should have low IGA different from natural teeth. IGA is composed of vertical and horizontal overlap, and they need to be checked separately. So we need to select and arrange anterior teeth considering many factors. After arranging posterior teeth, you can check in the mouth. However, if the patient has a lot of bone resorption and if we need to check lip support, after arranging the upper anterior teeth, we can put them in the mouth and evaluate aesthetics. At this time, we can check arch form, lip support, midline, and the overall length and speech. Recently, now on the chat of denall, it is very hot with questions from our audience. Let's have a look at them first. On the chat, Smile Again says, Professor Lee So-hyun, hello. I look forward to your lecture in this prosthodontics on Friday. 예쁜 하늘 says, I will enjoy your lecture. Next, Impulchobo asks the question, for skeletal class 3 malocclusion edentulous patient, do we need to use crossbite for the arrangement of full denture? In the case of a class 3 malocclusion, when a patient has a lot of bone resorption and arch relationship is not good, when the patient has normal cusp inclination, we cannot achieve normal balanced occlusion. I will talk about this a little bit more when I talk about posterior region. We can use cuspless occlusion or change the upper teeth based on Gissy's axial theory to provide occlusion for skeletal class 3 malocclusion cases. Okay,
아, 예. 골격적 상급 부정맥
for skeletal class 3 malocclusion, for teeth arrangement, I believe we need to separate the anterior region from the posterior region. For the aesthetic anterior region, we cannot do the crossbite, but we can do edge to edge. Exactly, it is very hard to treat skeletal class 3 patients. I myself try not to provide crossbite, but as you said, edge to edge. For the anterior region, the posterior region has angles like 83 degrees, something like that, or 80 degrees. That's the criteria for providing a crossbite.
그다음에
Next,
캡틴 아메리카
Captain Americano asked the question. A patient comes with natural teeth in the lower and a complete denture in the upper. The denture keeps breaking. The artificial teeth have been replaced with the strongest ones still. The denture base is broken. What is the criteria in selecting artificial teeth? The denture base is breaking. It has nothing to do with selection of artificial teeth. Yes, but as I see the question, the patient has natural teeth in the lower and CD in the upper. Actually, it is not easy to do a single denture. I will go over the types of artificial teeth and occlusal plane later, so I will address the question. It will be addressed later.
잠깐만요.
Wait a minute, please.
예.
Here is the question from Light. Can you tell me the August Prosthodontics on Friday schedule? Here is the schedule. August the 4th. It is about the delivery of CD, how to deliver and adjust a complete denture. It will be spoken by Professor Lee Jun-seok of Dankook University on the 25th of August. Complete denture complications will be spoken by Professor Park Chan-jin. So in August, 2 speakers will talk about the complete denture on the 4th and 25th of August.
여기
Next,
그다음에 우리가 이제 더위 탈출이 이런 분이
더위 탈출 asked, in the arch relationship of class 2 and 3, how do we determine the amount of vertical and horizontal overlap for the arrangement of artificial teeth? Establishing occlusion for class 2 and 3 are very challenging and it's unstable. Class 2 has a lot of movements. Class 3 less movements, so you need to have low incisal guidance angle for stable dentures. 인공치 배열 asks, do you arrange artificial teeth yourself? It'll be good if I do it myself, but in many cases I check the result. How do you instruct a lab technician if the technician is arranging the teeth? I believe if you communicate properly, dividing the work with a lab technician is much more efficient. So there are different areas of work between what I can do and a lab technician can do. This is a very good question. We look at the patients ourselves and anatomical situation with landmarks, but lab technicians do the work without patient's tongue or bones, so you need to provide a lot of information to the technicians, like writing a memo or mark on a model. Like you can write a memo or draw a picture, the standard line, the canine line. Yes, send the technician a lot of information, including photos. Do you have all samples of artificial teeth, so whenever necessary you pull one out and deliver it to the technician? No, not really. Communicating well with the lab is very important, and this is a very good question. I showed you various artificial teeth that is used in a lab, but a lab has many more artificial teeth samples, so you need to get a sample book from a manufacturer and you take a photo out of the sample book, send it to a lab which has all the artificial teeth samples from the various companies. So the company pamphlet has all the specifications, the distance of 6 anteriors, curve or straight line distance, and you specify which companies, which samples in the anterior or posterior regions. That is how you request. You request a guidebook from a company. Companies will send them to you. Soon you asked, for upper and lower edentulous class 3 patient, how do we provide anterior occlusion? Despite this is similar to the question before. Yes, you need to lower the incisal guidance angle as much as possible and provide edge to edge to increase patient satisfaction. We will have just one more question. How do you distinguish wrong arch relationship from skeletal class 3? The previous denture is closed for mastication like class 3. Do I need to arrange teeth in class 3 like previous denture or edge bite? How long do we observe unstable occlusion? I need to see the patient myself. I expected a lot of questions for class 3, so I was going to talk about it later, but the edge bite in the anterior. Me and my intern sometimes mistake our patients as class 3. Initial diagnosis is very important. Usually the upper anterior region is resorbed a lot, so we mistake a patient as class 3 or pseudo class 3 when they are not. When a patient's arch relationship is not normal, we can take a cephalo image to be sure. For the skeletal problems, as you said before, considering aesthetics and others, you can lower the cusp inclinations and anterior teeth inclination, and it would be good to provide edge to edge, and we can obtain stable stop in the posterior region. Professor, let's finish the interim Q&A. We are constrained by time. Thank you for the answers to the questions. I'd like to thank the participants who provided questions and supporting messages. Those questions unanswered will be answered during Q&A session after the lecture. Keep asking questions and you will receive coffee coupons after lucky draw. Please continue the lecture, Professor Lee. Sure, let me continue the lecture. I talked about aesthetic trying. Continuing with the anterior region. Actually, anterior and posterior regions are not separate, but in the anterior region, we are focusing more on aesthetics and speech, and for the posterior region, more on chewing function. As I said before, we need to choose artificial posterior teeth with proper cusp inclination in harmony with the end controlling factors. Compensating curve should be adjusted for balanced occlusion. Now we are choosing artificial teeth and arrange them for the posterior region. Inside the guidance, which was explained, patient age and neuromuscular system is very important. I will go over that in the next page. Complete denture is based on centric relation, and we will go over the importance of that. The upper and lower jaw relationship. When bone is resorbed, the jaw relationship may look different than the actual. It's very important to identify the remaining alveolar bone. Now you are looking at A, B, C, and D. According to the guideline, we are choosing artificial teeth. If teeth were extracted recently, the bone resorption would not be severe. So if teeth are mounted on the ridge, it would be more stable, supported by the ridge. If alveolar bone is resorbed like in C or D, depending on where the residual bone is, The denture can become unstable due to lateral pressure and affect the residual bone in a harmful way. So you need to consider the residual bone in choosing the teeth. Centric relation is very important for complete dentures with reproducibility of CR. As the most posterior limit regardless of teeth. Consciously or unconsciously, the mandible is positioned as CR in the posterior position. If CR is positioned anteriorly, not posteriorly, it may cause occlusal interference. It is important to establish the vertical dimension properly and CR in the mandible for complete dentures. Designing occlusion, you also have to check if patient has habitual occlusal position. If a patient has a habitual occlusal position, if you position the mandible too posteriorly, resulting in improper CR, the patient would feel more uncomfortable than before. If we find habitual occlusal position in the anterior and lateral parts of the CR, you should not insist on having severe inclinations of cusps. And if you choose them, you need to provide the freedom of centric so that the denture can be used more naturally. This should be considered, and you may choose to use cuspless teeth as well. Choosing artificial teeth, as you can see here, some teeth need to be eliminated. In that case, what teeth need to be eliminated? The first premolars, as they have least function among the posterior teeth, or the second molars. If bone is resorbed at the starting point of a canine, in many cases the posterior teeth would be inclined. Teeth should not be arranged in that inclined position, so we face a lack of space sometimes. Compared to the natural teeth, artificial posterior teeth tend to be buccolingually narrow and lingualized, reducing the occlusal force delivered to the residual bone. They are designed to enhance the stability of dentures. How do we choose the teeth? All these are available to help your choice. Depending on the form of occlusal surface, they are classified into anatomic, semi-anatomic, and non-anatomic teeth. They have pros and cons. This is rather wordy, but let me go over it. Anatomic teeth have superior chewing efficiency, aesthetics, and it is possible to reduce the cusp incline, and the cusp incline occlusal movement can be guided. But as you saw before in freedom in centric, the occlusal relationship is less flexible, and horizontal occlusal force can occur, which is harmful to residual bone. Occlusal adjustment can be difficult because of cusps. The residual alveolar bone can be resorbed, requiring relining. Non-anatomic teeth have almost no cusps, with low chewing efficiency and aesthetics, increasing horizontal mandibular movements. But this can be used for class 3 patients where jaw relationship is unstable and cannot be adjusted properly. Providing balanced occlusion would be a little bit more challenging because of lack of cusps. But its advantage is the disadvantage of anatomic teeth. Flexible occlusal relationship and low horizontal occlusal force because of low cusps. Less occlusal changes, and this can be easily applied to class 2 or 3. Originally, non-anatomic teeth were not necessarily 0-degree teeth, but these days only 0-degree teeth are remaining for the non-anatomic teeth. Teeth achieving lingual occlusion, which is in contact in the lingual side. Now we'll explain about it later. The lingually touching teeth are in the midpoint between the anatomic and non-anatomic teeth in terms of advantages and disadvantages. This is again the arrangement of posterior teeth. The teeth can be classified into these categories. The fully balanced occlusion has occlusion anteriorly and laterally. And lingualized contact occlusion using the lingualized teeth and balanced occlusion with 0-degree teeth. Lastly, this may sound unfamiliar, monoplane occlusion, which uses neurocentric concept, but this is not achieving balanced occlusion. However, the 0-degree approach is achieving balanced occlusion even though they don't have cuspal incline, as you saw before with the Hanau quaint, using other controlling factors. Now, let's have a look at the fully balanced occlusion. What is important here is that on both sides of CR, the maximum intercuspal occlusion should be achieved equally on many teeth, even though lateral and anterior movements are important. On both sides of CR, maximum intercuspal occlusion should be achieved, not only for lateral sliding movement, but for anterior sliding movement. All teeth need to be in contact. That is the concept of occlusion for complete dentures. It is associated with the BBO. Sometimes we cannot achieve the fully balanced occlusion in the anterior region because of aesthetic or speech problem, as we cannot make the angle too shallow. Then we can use the bilateral balanced occlusion. So Christensen phenomenon is very important when teeth cannot come in contact in eccentric position. This occlusion can occur in the posterior. In the case of natural teeth, under mandible protrusive movements, bilateral condyles move anteriorly and inferiorly, and under lateral movements, the balancing condyle moves anteriorly, medially, and inferiorly, excluding the posterior teeth in the shape of a triangle anteriorly and then laterally to protect periodontium and neuromuscles. As I said before, the teeth in the complete dentures are not attached to the alveolar bone, so they are separate from the bone and move in one unit. So denture stability is more important. That's why we need to achieve the fully balanced occlusion. We arrange teeth going against the Christensen phenomenon. This is unfavorable for natural teeth, but favorable for denture stability when it comes to complete dentures. There are so many different teeth types as shown in the guidebook. They include 33 to 20 degrees, and then 30 degrees, and also cuspalist teeth. It's not easy to select the proper cusp incline for the posterior teeth, but you need to consider what teeth are used by the lab that you are partnering with. Hanau quint should be considered for the cuspal inclines, as I said before. Sometimes we arrange the posterior teeth ourselves or sometimes not, and we already learned how to arrange them in hands-on. There are maxillary approach and mandibular approach. Maxillary approach arranges the upper anterior teeth focusing on aesthetics and then arranging the posterior teeth. The mandibular approach is used when alveolar bone resorption is severe. So lower posterior teeth are arranged first, focusing on the stability of the teeth. As shown in the diagrams, you need to remember that the result of maxillary approach and mandibular approach are the same in terms of teeth arrangement. The criteria is different, but the arrangement results in the same. And the virtual occlusal surface lines are different in the maxillary and mandibular approaches. They are not the same. You need to check incisal guidance, which affects the posterior teeth inclines. We learned various arrangement methods of posterior teeth as well as anterior. Pound's method, how to arrange teeth in the area from the canine mesial contact point and lingual and labial lines of retromolar path. Using this kind of method, you arrange the teeth. An easier way is to position the posterior teeth, the central groove on the line connecting the canine tip and the middle of retromolar pad. And it will lead to more stable lingualized denture. So you can look at this for your reference. This is the wax denture. I want to tell you what needs to be checked. First, the models should be well fabricated and mounted properly. If mounting goes wrong, the teeth arrangement cannot be made properly. Below, you can see mounting is properly done, but teeth arrangement is not very good. The mandible looks pretty long. Maybe the vertical dimension was not set properly, or the existing teeth were worn down severely, so you need to check the mandibular position from the frontal side. As I explained before, bilateral balanced occlusion, cross-tooth balance on the working side, and cross-arch balance on the balancing side. Such balance is very important to achieve a bilateral balanced occlusion. As you saw before, with the resorption of the bridge, occlusion should be lingualized to use a denture in a stable way. If we move the artificial teeth lingually, that is not good. It can lead to aesthetic problems. The second method is to lingualize the occlusal contacts by reducing the buccal side to reduce the contacts. Third, teeth with lingualized contact occlusion can be used, which was a question before. We learned how to achieve balanced occlusion in a patient with alveolar bone resorption. Using the lingualized contact occlusion is not that difficult to achieve. The mechanical freedom of non-anatomic teeth is maintained, and also showing efficiency and aesthetics of the anatomic teeth. The maxilla anatomic teeth were arranged. Mandibular cusp angle is lowered to about 20 degrees. Modified teeth can be used with marginal and transverse ridges removed, or normal cusp inclines can be reduced. So these are how they are arranged. On the balancing side, the contacts are the same. But on the working side, the buccal and lingual cusp contacts occur together, but not on the buccal side, so the unstableness due to the buccal lateral pressure is avoided. It has many advantages, but it is about at the halfway. Its mascatory efficiency is not as high as that of anatomic teeth. In this case, the occlusal relationship can be good, but aesthetically it is lower than that of anatomic teeth and higher than cuspiless teeth. But this can wear more, so you need to consider that. As explained before, the 0-degree cuspiless teeth can be used when jaw relationship is not good or unstable. As explained, non-anatomic teeth used to be not all 0-degree, but currently they are. Companies provide sample books introducing 0-degree teeth that you can choose from. Said before, 0-degree teeth doesn't mean that you cannot achieve balanced occlusion. What method can we use? Compensating curve for balanced occlusion. Compensating curve can be used, or as you will see later, a tilted second molar or ramp can be used. If ramps are used, you need to check the interference from anterior or lateral movements. It can be used when anterior incline angle is 10 degrees or less. Lastly, I would like to talk about the neurocentric occlusion, which is not achieving balanced occlusion among complete denture concepts. This is for a situation really bad, so that a complete denture is provided for the patient to eat something without giving any anterior incline angle. And the second molars have a gap of 2 millimeters. At the center of the ridge, the teeth are arranged using this method. So all the occlusal force is concentrated on number 5 and 6 teeth. That is the concept of this occlusion. We had a question about this before. This happens a lot, especially when the mandible is natural teeth, but also in bilateral complete denture cases. The teeth can be worn down like this under improper maintenance to prevent wearing or to recover the patients after the teeth are worn down. And if everything else is under proper maintenance and okay, metal occlusal surface can be provided or gold can be used. I see many patients who have worn down gold as well. We used to use a porcelain occlusal surface quite a lot, but it is noisy and has a high fracture rate. So these days I try to apply zirconia. If you look at B and D photos, there are natural teeth on the mandible and the severe wearing on the gold occlusion. So premolar areas were replaced with zirconia. So this has been the artificial teeth selection and arrangement that I have prepared today. On top of that, you need to consider concepts listed here. I believe they are introduced in the Prosthodontics on Friday seminars, such as vertical relation, horizontal relation, occlusal point, arch form, and occlusal scheme. All the concepts need to be considered harmoniously to have successful complete denture fabrication. Now let's have a full-fledged Q&A session. We had a brief Q&A session before. Let's look at the chat. 인공지 배열 asked the question, where can we get the gauge used to select anterior teeth? Actually, I brought one today. If someone brings it to me, I can explain. As I said before, you can ask a company and they will provide a guidebook and the gauge. Our position is very important. And based on that, anterior teeth can be chosen. What is the name of the gauge? There's no specific name for that. It is included in the set. Please let someone called 인공지 배열 later about the gauge. Yes, I will do that. Next, the 파란 하늘's question. When arranging teeth for complete denture, when do you use ceramic teeth in the posterior region? Usually we use a composite resin. When do we use porcelain teeth? In the posterior region, I don't really use a porcelain teeth in the region. If you insist, maybe when the opposing teeth are made of porcelain. As lower teeth tend to be worn down, that is right, you can use it, but they're not really used often these days. When porcelain and resin are used, they can wear and the color can be changed, so they are not used often. A question from 할 수 있다. To arrange canine on a record base, do we need to mark mouth corner or what else information? As I explained with the screen before, you need to mark the midline, alar position, and positions of mouth corner, lips, or high smile. The markings are for the lab work. Another question from 인공지 배열. Where can I get a tooth selector? You can ask a company, and they provide a tooth selector for free, or sometimes you need to pay for it. For example, if I use Endura teeth, you can ask Shinheung, which is providing Endura teeth. In the case of OSSTEM, OSSTEM provides Evocular selector and Evocular teeth and selector are available. 인공지 배열 asks a lot of questions. How do you select teeth color according to facial color? What is the criteria? Facial colors range from pale to warm colors. So tooth selector can be used for this. Artificial teeth have a variety of colors, so we use a shade guide. So a shade guide can be used. What is important is that you need to get the agreement from a patient. You provide 2 or 3 options, and a patient needs to make the final decision. Then it will reduce the complaints later. Otherwise, you can get a complaint for that. Captain Americano's question. When an arch is narrow, do we need to provide 14 small size porcelain teeth, or do we need to provide 12 teeth, eliminating 2 premolars? When an arch is narrow, you need to provide all the aesthetic anterior teeth and all posterior teeth, but sometimes you need to eliminate teeth or rotate. If 4 teeth cannot be inserted based on the distance from the premolars to retromolar pad, 3 can be inserted, but you need to obtain your patient's agreement to that. When you need to eliminate a tooth, you need to get the permission from your patient. Question from 인공치배열. Is philtrum the final midline guide? I think the guideline for the midline is the space between the eyes and the space in the forehead. That's what people look at. I believe the accurate midline is the line connecting there and the philtrum around the mouth. Okay, how do we easily select the posterior teeth? There's sizes and angles to consider. Depending on the ridge condition, the angles would be determined. If the ridge is good, we can use cusps. Otherwise, we need to go for the cuspless. In terms of size, distance between the canines and between canine and retromolar pad, so sizes can be easily determined based on that. The next question, IJH 6252 says, I need to take note of the low incisal guidance angle. Are there small differences in teeth arrangement depending on the arch form after forming a ridge wax? Sure, there can be differences when the arch is very narrow and triangular. It will look more natural if you rotate the teeth just a little bit. Next, Captain Americano. During a regular checkup, the posterior porcelain teeth are found to be worn down, leading to anterior region to come in contact, requiring occlusal adjustments. When do we need to replace the posterior porcelain teeth? They need to be maintained. The way to maintain is that you can replace the artificial teeth before wearing occurs to the artificial teeth. You can provide relining below the teeth, and you need to be careful not to lower the vertical dimension. Even if you use anatomic teeth with the inclinations, the ridge is disappearing like a cuspless teeth, and the patient feels the teeth as slippery and unstable or constantly moving. Then you need to replace the teeth before it gets too late. Next, 인공치배열. Do you use a lot of porcelain teeth? No, zirconia is used a lot. HYUKS Lee. For a denture to be covered by the National Health Insurance, do you usually use Endura? Yes, Endura or other composite resin can be used. It is not the only one recommended. So if you try products from various companies, you will find something that is better than others. Recently, CAD-CAM is used all the way up to artificial teeth all at once. Teeth arrangement is done automatically on a computer. You use various sizes and shapes. Can all the data handled by a computer? Yes, we also use the CAD-CAM dentures quite a lot. The final artificial teeth is not as good in terms of shade or resistance to wear. So when you use CAD-CAM, you really need to delve into anatomy. But still, you can use various teeth Just like selecting artificial teeth, there are a variety of sizes and shapes available. You can just choose one of them. Okay, we have so many questions left. We don't have time for all of these. It is good if we have more discussion time. My apologies that we cannot accommodate as many questions as we would like. So you talked about maxillary approach and mandibular approach. So from this question, Professor Lee can answer directly later to the questioners. So Professor Lee will contact you directly to answer the questions. KHJ's question: maxillary mandibular approaches, which one do you prefer? The next question, Chem Free: what is the criteria in selecting porcelain colors? Do you ever use cuspless porcelain teeth? 인공지배열: there are many different cusp angles. So many questions, and we cannot answer all of them. It would take 2 hours to handle all of these. So actually, the best question should be selected after handling all these questions, but we need to select the best one before we handle all the questions. However, the answers to the questions will be provided separately using social media.
따로 이렇게 카톡이나 이런 것으로 이제 드리도록 이렇게 하겠습니다.
Actually, we got the message from the broadcasting room that we can spend more time. So we can continue. 인공지배열 asked the question. We talked about color selection, maxillary and mandibular approaches. 인공지배열 asked the question. There are various artificial teeth cusp angles after mounting the final teeth. During occlusal adjustment, cusps are disappearing, so I have a doubt about selecting the artificial teeth in terms of the cusp angles. If lateral interference occurs, the cusps are removed. We need to select artificial teeth considering the cusp inclines, but the choice is limited. The teeth are not available for each degree of the incline. In this question, it says the cusps are removed during occlusal adjustment. It means the patient is experiencing some discomfort and it is in the process of being stabilized. When you expect something like this in a patient, actually in advance you need to sufficiently consider the teeth position, compensating curve, vertical dimension, and others. It would be better later. Yes, I believe we need to accurately calculate the occlusal plane and other factors, and we need to accurately diagnose the situation using an articulator to reduce the amount of reduction. So it is very important to accurately estimate all those in advance. So if you expect a lot of reduction later, you can choose a semi-anatomic teeth. Next question. In arranging artificial teeth, do you determine occlusal plane using a face bow? They are two different things. Face bow is about determining positions, the position of mandible, things like that. The face bow is not for determining occlusal plane, it is a transferring jaw relationship. 인공지배열 asks the question. The first and second molars can be eliminated. As I remember, there can be differences between the maxilla and mandible. I don't think there's difference between maxilla and mandible. What do you think? In the mandible, the first premolars have less function, that's why we eliminate them. But in the case of maxilla, aesthetically, if the patient shows a lot of teeth, you can keep the first premolar and remove the second. It is flexible. Next, the 파란 하늘 question. In the maxillary approach, in arranging posterior lower teeth, when the space is lacking, the first premolar is reduced mesiodistally. Why the first premolar? Because it has the least function. The next question is from the YouTube nickname Park Jin-young. You talked about habitual occlusal position. A denture treatment is provided to a patient. CR was established manually and the bite taking was performed to fabricate a denture, and the patient continuously complaining discomfort. I think it is because of habitual occlusal position, and I'm thinking about refabricating the denture. Do I need to provide occlusion for the habitual occlusal position, or do I need to consider CR first? As I said before, you need to make a judgment whether the habitual occlusal position can be changed. If the existing denture with the habitual occlusal position can be changed to temporary denture, and it is important that you have the process of evaluating if that can be changed. And if you omit the process and fabricate the final denture, this can happen. I believe in this case, Mr. Park thought the first thing was the interim denture, and it is tried on a patient and CR was established, and the CR can go wrong, therefore. So you need to consider your patient's condition and your clinical experience. The textbook answer is the CR. If possible, treatment denture should be used and CR is determined. And the questioner is starting again, and he thought the previous one is the treatment denture and the next one final denture. But sometimes something that we thought would change is not changed. You need to check the temporomandibular joint, the health status of the joint. If there's a problem, you need to treat it along with providing the complete denture treatment. You need to consider the possibility of no change in arranging teeth and maintaining a complete denture. Smoky pink one. I've never used cuspidless teeth. Do patients get used to it easily? We don't use cuspidless teeth a lot, but rarely we use it. Therefore, you need to understand it. Patients do not like them because of aesthetic problem. It is not pretty, it is flat, and sometimes it is pushed by the lateral force. But this can be used when a situation is really bad. Resin Choi, have you applied clinically the zirconia occlusion? How is the result? Zirconia occlusion, maybe zirconia teeth. It's not artificial teeth. We use zirconia, and it is milled and it is printed, and we continuously research them. When zirconia is printed, the teeth feel heavy and not very well printed. But we can make only like a full veneer crown or occlusion. If we use it similar to the metal occlusion, patients are very happy and it is good for us too. Teeth are cut and attached. 교합평면, please introduce Papbo due to constraint of time. We cannot answer it now, maybe next time. Next, Bora. In terms of occlusal adaptation, true bite seems to be comfortable for patient in terms of wearing, but patients who adjust to anterior or ceramic teeth don't seem to adjust to the true bite. Maybe that is due to the different formulation of the teeth, cross-linked or composite resin. That can make a little bit of difference. And they will wear down a lot. Yes. Let's go to the next. Actually, we handled all the questions. 슬기로운 치과생활. Professor So-Hyun Lee, thank you for the good lecture. Professor Lee, thank you very much for your lecture, and thank you for handling the questions very well. The best question, Professor Lee, can you choose the best question? Today, many people asked the questions, and do I need to choose just one person? Right, just one person. It is regrettable. The person asked a lot of questions from the beginning. It is difficult to choose just one. 인공치 배열 and Captain Americano asked a lot of questions, and today the one who asked the question from the beginning, Captain Americano, is the winner of the prize. Congratulations, Captain Americano. Congratulations, who is selected as the best questioner. We will contact you individually. Those who are lucky to get chosen for coffee event, you will get the short text message on Monday. Professor, do you have a last word for colleague dentists who are studying really hard joining us in this complete denture lecture? Time flies. Today is the second of the 3 dog days. I hope you are enjoying summer. This morning, the rain stopped. It boosted my mood in delivering today's lecture. Treating complete denture is not easy. Sometimes it feels difficult and sometimes we want to give up on it, but with good communications with patients and lab technicians, as you saw before, we can keep patients aesthetic and functions, and it can be a wonderful treatment for patients to increase their quality of life. Patients can get healthy and satisfied when the treatment is provided, which makes me feel satisfied and rewarded. I hope today's discussion is helpful for you clinically, and you will remember when you see your patients after this weekend. Thank you for your attention. Thank you for your invitation. Thank you for your lecture. Thank you, the audience of Prosthodontics on Friday, for joining us in this lecture provided by Professor Lee So-hyun. I hope this Prosthodontics on Friday is a good opportunity for you to get various tips in terms of complete denture and how to arrange and select artificial teeth, the unanswered questions, and if you have any further questions, Professor Lee So-hyun will answer them later. As was introduced before, the next lecture will be about mounting adjustment and patient management for complete denture to address the difficulty in adjusting to a denture. The speaker is Professor Lee Jun-seok of Dankook University School of Dentistry. Thank you for staying with us until the late hour. Thank you very much. Thank you.